It's a real pleasure to be invited to present at the 15th Advanced Academic Rheumatology Review course. My name is Francis Kynaston Pearson, and I'm a consultant rheumatologist working at Mediclinic Parkview in Dubai. I'll be presenting at the Fellowship in Training Day, and I've decided to put the presentation online for anyone that would like to catch up on the slides and presentation after the event. So today I'm going to be talking on the topic of DMARDs and biologics and covering really a very large area. So covering considerations before you start these medications, what we might need to think about in terms of pre-treatment workup, that might include vaccinations, and then ongoing treatment plans, including things like side effects to watch out for, typical treatment protocols, ongoing monitoring and vaccinations. So this is really a very large topic, and I will go through this a little bit more paced fashion on this online video. Then obviously I have time to deliver at the AdARRC review course presentation. So my disclosures, none of these have any relevance to this upcoming talk. So the sources that I have used for this, well, I'm a British trained rheumatologist, so I've started by looking at the guidance that I've used in clinical practice in the UK from the British Society for Rheumatology, particularly on things like how do we prescribe DMARDs for pregnancy and breastfeeding, what the kind of safety monitoring is for standard DMARDs, and then the monitoring for targeted and biologic DMARDs. I've also looked at EULAR guidance, and some of these are EULAR ACR guidances, again looking at safety in pregnancy, relationship of DMARDs and biologics to cancer, and ACR, particularly looking for perioperative management, because there's not many international guidelines on perioperative management, and actually the practice that I had in the UK differs slightly. That was a local practice, and so I've tried to sort of incorporate more of the ACR guidance in terms of pausing medications around operative interventions. The learning objectives from today's session are as follows. So we're going to start with some real basics. I'm not going to be going into enormous degrees of pharmacology, pharmacodynamics, pharmacokinetics, but a bit about the basic mechanisms on how these DMARDs function. I'm going to discuss what we do in terms of pre-treatment considerations, the kind of screening and baseline investigations, any pre-treatment vaccinations that should be considered, highlight the main side effects. With side effects and risks, it's an impossibly long task to do to completion. Anyone who's taken any medication for anything will know that the SPC, the details that you have in the medication box, are vast and cover just about anything you can imagine. But we do need to give our patients enough information to make informed consent decisions, and of course be aware of the considerations for the concerns as the prescriber of those medications. I'm going to look at monitoring schedules. Where there's guidance, I'll try and lay this out. In some of these, it is less clear-cut exactly how frequent you should have them done, but I'll try to put in some practical tips in terms of what might be sensible in clinical practice. Look at the guidance around surgery, but also other special circumstances like pregnancy and breastfeeding, and then have a run through what we might typically use as an induction regime for these medications. The resource that's going to be provided at the end is this video that's posted on my YouTube channel, but also a QR code to my website. In clinical practice, I find it can be quite challenging to go through all of this at the same pace with the same quantity and quality of information to every patient that I start DMARDs on. So in practice, what I recommend to my patients, if I'm going to start a DMARD or a biologic, I point them to my website. I ask them to have a look at the resources I've created there, because it provides a pretty good overview. It's not completely extensive, but it's more than enough information for most people. I've given them links on each of the medications to resources such as those from the UK charity Versus Arthritis, and they have a very nice patient information leaflet. For some patients who really love all the detail, I've given the link to a website, drugs.com, in case they really like having lots of information. It's interesting, patients can fit broadly from research into two categories: information seekers, who like lots of information, and that's around 80% of our patients, and information avoiders, who find it really quite anxiety inducing and really only want the information that they need. So there's lots of scales of information, but I do want patients to start medications being aware of what they should watch out for, which is why I use these online resources. And I normally go through a quick question and answer session just before prescribing the medication. So what drugs are we going to cover in this talk? DMARDs, I'm sticking to the most common DMARDs, that is hydroxychloroquine, sulfasalazine, methotrexate, leflunomide, and azathioprine. Immunosuppressants, and I have separated mycophenolate because it's more immunosuppressant, although you could argue it straddles being a DMARD and an immunosuppressant. Cyclophosphamide and prednisolone, which I would classify as an immunosuppressant, albeit that it is incredibly complicated in how it works. And then targeted DMARDs, so that includes biologics and small molecules. For time reasons and because they're less commonly used, I'm not going to cover calcineurin inhibitors like cyclosporin and tacrolimus, old-fashioned drugs like penicillamine and gold, and then I've decided not to go into apremilast, again, just on time basis. Drugs that are less commonly used or are in the pipeline, like TYK inhibitors, CD19 blockade, minocycline, IVIG, and avacopan, a C5a inhibitor, I've also not covered in this presentation. They are much less commonly used, of course. So let's start with talking about the synthetic DMARDs. So the mechanisms, again, this is an overview rather than in too much detail. Hydroxychloroquine has its impact predominantly on T cells, and the accumulation within these T cells has an inhibition of cell surface receptors known as toll-like receptors, and the downstream effects can impact certain cytokines, chemical messengers, things like IL-1, IL-6. But it also has a mild anti-thrombotic effect, and this is particularly useful in conditions like lupus, where we've shown that the use of hydroxychloroquine is associated with an overall reduction in morbidity in these areas. Sulfasalazine is an interesting one. I mean, in common with a lot of these DMARDs, we don't always have a full appreciation and understanding of everything that they do, and I think that's fair for sulfasalazine. There's two components. There's the 5-ASA, and this has some interaction in the gut. Some people postulate that perhaps it has an action on the microbiome of the gut, and maybe this is affecting immunogenicity that way. And then there's the sulfur-pyridine aspect, which has got an anti-inflammatory and perhaps a reduced proliferation impact for conditions like inflammatory arthritis. Methotrexate, which is our staple go-to medication, we probably know impacts folic acid use, and folic acid is an important vitamin in terms of cell proliferation, and also has some anti-inflammatory effects via accumulation of adenosine intracellularly. Leflunomide works on dihydrorotate dehydrogenase, and this is an enzyme involved in the production of new purines. Purines, of course, are required for novel DNA synthesis, so you can inhibit DNA synthesis and suppress proliferation in that mechanism. And azathioprine works in a similar way by being a false purine, which is incorporated into the synthesis of new DNA, and this will affect a range of cells, but particularly lymphocytes. So I'm going to start with what I might call the light DMARDs. In some ways, I don't like this term because obviously the DMARD is about targeting the DMARD to the condition. So if it's the right targeted DMARD, you don't need to be on a so-called heavy DMARD, but these are generally easier to tolerate for most patients and perhaps less prone to side effects. So hydroxychloroquine and sulfasalazine, I think, fit into this category, and I'm perhaps more liberal using these medications when the evidence for inflammation is less strong, but I still want to try and see if something is potentially inflammatory there with a medication. For all of these, I'm going to talk about the pre-screen, the side effects, which are the common ones, and then some of the rare ones to watch out for, how we monitor, the vaccines we might need to think about, infections that we need to think about what to do if you're suffering from an infection, and how we typically initiate. And I'll follow a similar course for all the medications that we run through. So for hydroxychloroquine, probably all aware that having an eye check is important. Probably not essential to have bloods taken, although you most likely will have done as part of the diagnostic workup to decide why you want to start this medication. Mostly these are relatively common side effects that we get with any medication, non-specific things like a bit of GI disturbance and headache. Early on, some patients may have a bit of blurred vision, and that's different to this well-known issue about retinal toxicity that takes usually a long time to take effect, and we don't really properly screen for it in terms of OCTs until they've been on it for a number of years, typically 5 or more. Rarely people get muscle weakness and arrhythmias. In terms of monitoring, every year I'd recommend seeing the opticians for the first 5 years. If they can get a baseline review that includes an OCT, which many opticians do these days, that's great because you've got that to compare with. And at the 5-year mark and annually thereafter, an ophthalmology assessment with OCT becomes more important. It's also useful to point out things like sun sensitivity when you're having your follow-ups because of the risk of easy burning, depigmentation, which can sometimes occur in the skin or hair. There's no specific advice about vaccines, so there's no pre-treatment vaccines I think you have to have, and there's no regular vaccine schedule you have to have, but you may still feel you would like to recommend that if they have an autoimmune complaint. If you're suffering from an infection, you can likely carry this on unless there's a direct interaction between the antibiotic and hydroxychloroquine. There's no specific reason to stop hydroxychloroquine in most cases. The initiation and continuation is done on a weight basis, and we aim not to exceed 5 milligrams per kilogram. Doses above 5 milligrams per kilogram do significantly increase the eye toxicity with time. There are 300 milligram pills available, which can make it easier than doing what we historically did, which was to alternate 200 and 400 milligram doses. So for sulfasalazine then, obviously, if you have a sulfur allergy, it stands to reason you wouldn't want to give sulfasalazine, but beware of aspirin allergy as well. I think it's reasonable to do a normal workup, so blood count, kidney and liver function, at the very least transaminases and albumin, but I quite like a full liver function test, which I know can be a problem sometimes with insurers. If you're in a really rare situation like G6PD or porphyria, then this is probably not the right drug. I also think it's worth being aware of anti-nuclear antibody. So if you have a very strong anti-nuclear antibody, then there may be a greater chance of having adverse effects. So I tend to avoid sulfasalazine if someone has an ANA of 640 or above. And if I do consider it, it's not my first line treatment. This gives more GI side effects, and headaches as the most common things. The sulfasalazine itself is quite strong pigment to the actual drug. So having orange secretions, so orange urine or orangey tears, is something you might want to warn patients about, because obviously that could appear alarming if you haven't been pre-warned. Occasionally with sulfasalazine, and frustratingly it's rather unpredictable, you get sudden cytopenias. And that's why you do need ongoing monitoring, even in someone who's tolerated this quite nicely. Some people go off their food from the GI side effects and occasionally get liver function derangements. A more severe allergic reaction might be something like DRESS, where you can get a more pronounced allergic drug reaction. For monitoring, we normally start with the baseline, which would be the kidneys, liver, and blood count, and then monitor that on a 2-weekly basis until you've got to around 6 weeks. I then would normally do another 6-week test at the 3-month point, and if you've been completely stable across all those bloods, you can go on to a standard monitoring DMARD protocol, which I will discuss in a moment. With sulfasalazine as well, I don't tend to suggest that they must have pre-treatment vaccines. And although I might suggest that they have things like flu vaccine as they go around, a little bit less pushy about recommending that vaccines must be undertaken. For infections, consider stopping if you're taking an antibiotic. This one, I think it's up to the clinician to decide, and obviously the patient's overall state of health and frailty. Typically, I might suggest, look, if you're on an antibiotic, especially if it's an intravenous one, you probably should just pause your sulfasalazine. The initiation, we build it up slowly over a period of a few weeks. So the first week, 1 pill a day of 500 milligrams, then 1 in the morning, 1 in the afternoon, 2 in the morning, 1 in the afternoon, and then 2 twice a day. You can build this up to 3 twice a day, so 3 grams in total, as they're half gram pills over time. Okay, so we talked about light DMARDs. What about the so-called full-fat DMARDs? So that's methotrexate, leflunomide, and azathioprine. And I'll compare these in each section across the whole of the subheadings here. So in terms of pre-screen, they're broadly similar. So hepatitis B, C, and HIV, I would request in all patients commencing these drugs, and a baseline chest X-ray, both for looking for infections, ruling out anything of concern, because you do sometimes pick up rather worrying features or even cancer in some patients. And for methotrexate and the leflunomide, I'd certainly inquire about pregnancy, and I'd have a very low threshold to actually test for pregnancy if there's any doubt, because you do not want to be starting these medicines, especially not early on in pregnancy. For azathioprine, test them for TPMT. This enzyme assists in the breakdown of drug. If you have alleles that would suggest you are a poor metabolizer, then you are more likely to suffer some of the effects and perhaps more likely to suffer from cytopenias. And just a reminder about gout medications, because of the way that most of these work on xanthine oxidase, again, this can affect the breakdown, and you end up with a major potentiation of the azathioprine, which can lead to cytotoxicity and cytopenias. In terms of side effects, pretty similar in the sense that they all can upset your tummy. They all can lead to liver function derangement and cytopenias. Methotrexate may give some hair thinning and mouth ulcers and mouth soreness, especially being taken orally. Obviously, the subcut version can assist with that. Leflunomide, you can have a rash with and some weight loss, which is slightly different. Weight loss is quite common with leflunomide, and azathioprine, same non-specific side effects. But on the rare occasions, early on, you can get pneumonitis, which we typically associate with methotrexate, but you can get this with leflunomide as well. This is different to interstitial lung disease. And although we still have concern about methotrexate and leflunomide to some extent in interstitial lung disease, actually the data really doesn't bear that out. In fact, probably it's better that they're on something like methotrexate if the interstitial lung disease is from an immune cause. It's a reaction and an inflammatory response, pneumonitis, not interstitial lung disease, that we see early on, and it doesn't really happen beyond the first 6 months in most cases. So if you haven't had that reaction in the first 6 months, you are likely to be in the clear. For the flunomide, perhaps there might be some issues with neuropathy in the long term, dyslipidemia, and severe weight loss. And for azathioprine, one of the rarer things is about a febrile reaction that you can get that looks like they're having an infection, but it's actually an azathioprine reaction. Now, all of these have a potential risk of cancer. I did a previous talk on DMARDs and cancer risk. I think as much as we need to have this conversation with our patients, because obviously if our immune system is being disrupted by medication and our immune system has the role of destroying and removing cancerous cells, then we may increase cancer risk. But it rather ignores the fact that having an uncontrolled immune system itself promotes cancer, and we're not really looking at significant rates of increase of cancer in the use of any of the medications that we use. Though I would say with azathioprine, skin cancers in particular are worth watching out for and referring to a dermatologist if you have concerns about non-melanomatous skin cancer. So for monitoring wise, the standard protocol, that was week 0, week 2, week 4, and week 6, followed by a week 12 review as you're escalating, and then a 3-monthly monitoring as we move forwards. If you're making an alteration, I tend to say weeks 2 and 4 after the alteration to the dose is sensible before reverting to your standard protocol. For leflunomide, I would add in a blood pressure and weight check because hypertension can occur. And for azathioprine, we mentioned that you may want to think about a skin assessment. So in terms of vaccinations, I do advise and refer my patients to family medicine to consider a pneumonia vaccine before starting all of these medications. I do advise having annual flu vaccines. COVID, I tend to suggest they follow the recommended guidance, and obviously that is an ongoing situation as the years go past from the pandemic as to whether they should or should not be having COVID boosters. Shingles boosters, particularly if you're 55 and over, but it might be worth considering that in patients who have other reasons to be immunocompromised. Live vaccines are probably best avoided. You may consider these in some situations on a case-by-case basis, but certainly routinely I would suggest things like yellow fever are not taken after you've commenced methotrexate and other drugs like this. For all of these drugs, if you're requiring antibiotics, my recommendation is you just pause the DMARD until such a time that you have completed your course of antibiotics. When starting, I typically would start at 15 milligrams. You have some scope. If it's an early inflammatory arthritis and getting control is crucial, you might go in this kind of regime. Perhaps if it's low grade and you're worried about side effects, you could start at a lower dose, but typically 15 and then escalating relatively quickly to 20, perhaps at the 6-week mark, not going usually above 25 milligrams. Leflunomide is 10 or 20, and then for azathioprine, I usually start at 50 and work my way up to the maximal milligram per kilogram dose suggested here. What about other considerations? So pregnancy, breastfeeding, and surgery. Well, there are some drugs that are pretty safe. Hydroxychloroquine, sulfasalazine, azathioprine. There's obviously no such thing as completely risk-free. At the time of this presentation being recorded, we've just had the interesting announcements from the United States on paracetamol in pregnancy and autism. I think it can create an enormous amount of anxiety, understandably, in expectant mothers. But we're not dealing with an imperfect toxic drug and a perfect solution with non-pharmacotherapy. So to maintain control of conditions like lupus and inflammatory arthritis during pregnancy is important. And these drugs have been studied extensively and are considered safe to continue throughout pregnancy and breastfeeding. You may wish to pause this if there's issues with conception in men, particularly sulfasalazine. Now, for methotrexate, if you're a man, you can continue this if you're looking at family planning. but women should stop this 1 month prior. And this is the latest guidance. It used to be 3 months, but at least 1 month before. Now, breastfeeding, the levels are pretty low that go into the breast milk. Again, we tend to suggest stopping, but it will depend upon how aggressive the disease is and how much disease control is important versus exposure of methotrexate to the young child. For leflunomide, it's a bit of an issue, and for this reason, it's not an ideal drug for young women of childbearing age, because you either need to wash the drug out of the system or consider stopping it a very long time in advance of conception planning. Surgery-wise, these drugs can be continued throughout surgery without any real concern, so I don't suggest they stop it. There will always be exceptions to the rule, and there will always be a surgeon who really doesn't want it continued, but there is a risk of flare if you stop this, so I would suggest that we just continue them unless there's an exceptional circumstance. Let's talk about the immunosuppressants then. So let's have a run through the mechanisms. I'm not going to go through the whole of corticosteroid mechanisms, partly because I don't think it's entirely understood in its totality, and partly because I could do more than an hour's talk just on steroids. But there are some rapid effects, and we know that because we give steroids in emergency situations and sepsis and anaphylaxis. And then there are the long delayed impacts that last weeks or even longer, and that's through gene expression and cell signaling cascades. Mycophenolate inhibits an enzyme, monophosphate dehydrogenase. This is involved in a different purine, and again, we know what the role of purines are. We've discussed that. This particularly suppresses the lymphocytes. Now, cyclophosphamide is converted in the body to mustard gas, effectively. So it is a toxic product, but we have to. I think we had to be honest with our patients without terrifying them when we say we're thinking about treating them with mustard gas. But it does have a toxic action, cross-linking the DNA, and obviously having its action profoundly on rapidly dividing cells, especially lymphocytes. And it is a very useful drug when you need to get control over a condition rapidly. So looking at the aspects when we're starting considering these. So for the pre-screen, if you're going to start steroids, we need to think of all of the long-term issues of steroids. So we know that it increases your blood sugar, and it's not going to help your diabetes control, dyslipidemia, osteopenia and porosis. And actually, in very high doses for vasculitis, it can have cognitive and psychiatric effects. So just consider those before starting. For mycophenolate, it's a pretty similar picture to other DMARDs. And for cyclophosphamide, because it being more immunosuppressant, it's worth thinking about things like TB, and even in some situations, other viruses, whether or not you've ever been exposed to varicella, Epstein-Barr, cytomegalovirus. Sometimes it can be helpful to get a baseline, just because if you were to be infected the first time with one of these viruses and you don't have evidence of IgG, you may get a more pronounced or severe infection with these viruses. Side effects wise, well, let's not do this at too much length for steroids, because we could be here all day, but steroids are wonderful drugs and evil drugs, and the amount of steroid side effects is enormous in the long term. They are the stress hormone. They allow us to function in a stressful situation for a short period of time, but they will catalyze the body. They will eat away at muscle and bone. They will raise sugar levels. They'll cause cataracts, glaucoma, infections, and skin thinning, and you name it. Mycophenolate can upset you GI-wise, cytopenias, and is not a drug that's safe for pregnancy, as it's teratogenicity. And then cyclophosphamide, you can get hair thinning. It's less common to see hair completely drop out in the way that you might when this is used in a full-blown chemotherapy regime, when you're combining it with, say, full-body irradiation for aggressive blood cancers. Fatigue and feeling quite sick is not uncommon. It's removed from the body through the kidneys, and therefore it accumulates in the bladder and can cause irritation and cystitis, hemorrhage, and in the long term, there's a cancer risk to the bladder. But we use secondary drugs at Mesner to try and reduce the issues with the bladder. Rare side effects: avascular necrosis, psychosis, myopathy, hair loss, infertility, malignancy of the bladder in particular. Monitoring wise, well, glucose or HbA1c to see if we're disrupting their metabolic health. DEXA at baseline, I think, if you're going to be putting someone on long-term steroids, and probably regularly once they're on the medications, then you might want to consider looking for things like cataracts and glaucoma, measure lipids and weight. For mycophenolate, standard protocol. For cyclophosphamide, you're going to be monitoring it for when they're coming in for their infusions, or on a regular basis if you're giving this orally. There's some school of thought that oral may have a faster onset, but most people prefer to give cyclophosphamide intravenously because there's a lowered cumulative dose, and you want to make sure there's not emergence of hemorrhagic cystitis. Vaccines, normal recommendations about flu and COVID, shingles as well, and pneumonia. And if you're on more than 7.5, I think you should avoid live vaccines. I think 7.5 milligrams of steroids is certainly up there with all the DMARDs, and high doses above 15 milligrams, I think, is really quite immunosuppressant. And sometimes we overlook just how much risk comes from high dose steroids in terms of infections, and atypical infections in particular, pneumocystis and fungal infections and things. Mycophenolate, similar advice to the other DMARDs, and similarly with cyclophosphamide, avoiding live vaccines with all of these, really. The only difference here, obviously, if you're suffering an infection and you're on a longer term steroid, you can't mount the usual steroid boost that we do as a steroid stress response. So typically in low doses, I'm not suggesting if they're on 40 that you give them 80, but if they're on low doses, you might want to double that up. So if they're on 2.5 milligrams, you give them 5 milligrams. If they're on 5, you might give them 10 milligrams during an infection. The other ones, of course, we will stop during antibiotic treatment. For initiation, lowest possible dose at the shortest possible duration. I think that anyone going on this for more than 6 weeks should be started on calcium and vitamin D as a minimum. And if they are over 50, then you probably want to think about adding in a bisphosphonate, plus minus things like PPIs if needed. Mycophenolate, you can go anything from half a gram a day to 1.5 milligrams twice a day. And cyclophosphamide, the packages that will be based upon the various different trial data. So it's condition based and it's milligram per kilogram based. So I would follow whichever regime you're considering using for whichever particular diagnosis you are treating. Considerations elsewhere. Steroids, it's pretty safe through pregnancy, but they will have some considerations. So if anyone is going to be on long-term steroids or multiple courses, you probably want to make sure the obstetric team and potentially the pediatric team are aware of that. We do not want to be giving mycophenolate or cyclophosphamide in pregnant women. The only caveat to this would be in complete emergencies where we have no other option. So if we're looking at end organ threatening or life-threatening disease, then we may need to consider cyclophosphamide in spite of its toxicity. But that's obviously a case-by-case discussion with the patient and all of the other clinicians involved in the care. As regards to preconception, both men and women may want to get some form of conception guidance and counselling, and talk about whether they freeze sperm or eggs. Actually, in a young man or woman, there's a pretty good chance that even after cyclophosphamide treatment, fertility will be unharmed, but the risk is there, and that discussion should take place Unfortunately, that it depends upon where you are working, what the setup is, but the delays that could occur in some settings, and I know that where I was working previously in the UK, it wasn't that practical to delay what was a life-threatening treatment um, for egg harvesting, and you may have insurance issues or payer issues if you're in a state-paid healthcare system that will be ones to cross in terms of egg harvesting before starting cyclophosphamide. For surgery, usually you just double the dose around the surgical period if it's a low dose, or try to reduce the dose down if you're on a reducing dose before surgery. And obviously, if you are planning surgery, you probably would plan it around the cyclophosphamide being completed. But if it's an emergency surgery, then you just have to go ahead and do it. So now we come on to biologics and targeted synthetic DMARDs. So this isn't going to be a full run through immunology, but I thought it might be useful just to run through the kind of targets that we have. So these are the ones I'm going to talk about, where these chemical messengers or targets exist, and then the impact. So for TNF, it's produced by macrophages, dendritic cells, T cells, a whole variety of cells. And the impact is predominantly in driving granuloma formation. Granuloma is a way in which the immune system can respond to infections, producing this constellation of immune cells, especially helpful for intracellular bacteria like the Mycobacterium bacteria, and also promotes angiogenesis, repair, and as the name suggests, may have a role in tumor removal, though later science has really not shown a significant increase of cancer risk. For IL-1, it's similar cells, dendritic cells, neutrophils. This is activated via the inflammasome, which you may recall is something I tend to think of it as like a cellular drill, in that it drills little holes into the target cell and is responsible for inducing fever, endothelial activation, and it's that auto-inflammatory response which is quite aggressive, and you see that rapid onset of inflammation in conditions like gout, but also the fever syndromes, FMF, TRAPS and CAPS and so on. IL-5 is a much more specialized interleukin produced by Th2 cells. When we think of IL-5, we think about eosinophils, and we think about fungal parasites, helminth, worms, all those kinds of infections. And in countries where those infections are less endemic, there may be role in allergy and things like asthma and atopy. IL-6 is our kind of master acute inflammatory cytokine, and this drives the acute inflammatory process, which works on the liver, and among a whole range of other effects leads to the production of CRP. So really important to understand that blocking IL-6 obviously prevents you from effectively making CRP, even though it doesn't prevent your immune system from being activated. For IL-12, we're looking at differentiation of cells for the Th1 type cells, and this is important for things like interferon production, again useful for mycobacteria. The IL-17 is produced by T cells, Th17 type, and this is about mucosal defense. So we think about gut in particular. And so there's an issue about potentially viruses, extracellular bacteria, and fungi, and not in terms of its function. So that would also be a risk to consider. IL-23 expands Th17 cells, which can lead to increased IL-17. So you can get a picture of how these 12, 23 blockers have a similar range of impact to the IL-17 because they are upstream effects. CD20 is a protein that we find on B cells, and you need it in order for the B cells to graduate from B cell school. And if they don't express it properly, they will not graduate. So by blocking it with CD20 blockers, we effectively take the B cells out of their graduation process and they cannot function. And they're useful for encapsulated bacteria, some viruses, things like hepatitis in particular. BAFF is produced by myeloid cells, and it's a B cell co-stimulator on BAFF or BLIS. So again, important for immune tolerance balance in health. JAKs are a range of proteins on the inside of the cell, and they congregate to form complexes, and there are different subunits like JAK1, JAK2, JAK3, TYK2, and these have a huge range of impacts because a huge range of extracellular cytokines will signal through a JAK pathway. Interferons produced by dendritic cells and fibroblasts, and these are important, especially MHC class 1 upregulation, which is useful for viral responses. And abatacept, because I couldn't really think of the best way to mention this, but it's the CD28 co-stimulation. So it's important for T cell activation, which has a role in viral defense, bacteria and fungi, but also in tumor surveillance as well. So what baseline screening should we do for biologics, and how does it differ? Well, in essence, it doesn't early on. We do the same kinds of things. And one question might be, should we repeat the screening if we've just done screening for the DMARD? And I think partly that depends on how recent, but it is useful to do the repeat screening. Our patients could contract hepatitis B or C or HIV, or could have had a false negative on the first screen. And if we're going to be making a treatment change where this knowledge will be useful, I think it's not a huge request to repeat hepatitis B, C, HIV, and a chest X-ray. But if you've just done them 3 months ago when you were starting methotrexate, you probably don't need to repeat that now that you're going on to a biologic. For TB, now it's really essential for anti-TNF. I think that you could make an argument to say you don't have to do quantiferon checking for some of the biologics, but I think if you hadn't done a quantiferon and they then ended up with reactivation of TB, or even they were infected for the first time with TB, you're going to have a bit of a hard time explaining that one away, even if you can mechanistically say this interleukin isn't associated with TB clearance. It's an uncomfortable position to be in, and I think doing a T-spot or quantiferon is good practice before starting a targeted biologic, targeted DMARD. For some, you'll need specific tests like dsDNA and complement. It's useful to have understanding about major illnesses, and we'll discuss this in some of the next sections about side effects to watch out for. But clearly, if they have liver or cardiac disease or cancer, that's a consideration. If you don't know whether they've had varicella, chickenpox, then I think you could do an IgG and consider a vaccination, because it could be quite nasty to pick up varicella for the first time with no previous exposure. In some groups, you'll consider HPV vaccine, and as previous, a shingles or zoster booster. And it might be worth doing a pregnancy test, particularly for some drugs, which we'll discuss later, like JAKs, that aren't really advisable for use in pregnancy. And as always, if you have a very immunocompromised patient with connective tissue disease or vasculitis, CMV, EBV, I think, can be helpful. For specific drugs, you may need to think about baseline screening in terms of blood pressure checks, which we might probably be doing anyway. Lipids are useful for IL-6 blockers. So, side effects. Most of these will have commonality, just like the DMARDs had commonality. You're going to have a risk of having a reaction where you inject. And this is where you can consider switching to a biosimilar agent if there is an option, because there may be different preparations, different preservatives, different needle gauge sizes, different mechanisms by which you inject that suit patients better. TB reactivation, demyelination, I think, is the one we really need to discuss with TNF. So if it's a family member, it's a consideration. If it's first degree, I think you might need to think very carefully. And obviously, if it's a personal history of things like Guillain-Barré or MS, then you really can't go down the pathway of anti-TNF. Cardiosuppression is only really relevant in end-stage cardiovascular disease. Drug-induced lupus is thankfully very rare, but can happen. Cancer, I'm not going to discuss the cancer risk for these because I think I've discussed that in the earlier slides, but it's always worth pointing out that anything that interferes with the immune system, as we've said, could possibly increase your cancer risk. For IL-1, things to watch out for, maybe there might be an increased cardiovascular risk in some of them, like canakinumab, and maybe a risk of pyogenic bacteria. For IL-5, not surprisingly, given its role in helminths and parasites, that may be an issue, and there's a small risk of arrhythmias. For IL-6, apart from being perhaps a bit more immunosuppressant than some, we need to think about diverticular disease because there's an increased risk of diverticular perforation, and dyslipidemia is another one. The other thing I think it's really important to point out to patients so that they're aware is that if they get an infection and they come to hospital and a doctor who doesn't understand an IL-6 inhibitor does bloods and says they're all normal, you can go home, we need them to know that that might not mean they're well, because obviously the CRP is going to be suppressed and that is not going to reassure a rheumatologist that there's no infection, but it might reassure someone who isn't familiar with how these drugs work. 1223s, bizarrely, one of the issues could be joint pain as a side effect, despite its use. Fungal infections, given the role in mucosal defense, which we see as a commonality across the 1223, 17, and 23 inhibitors. For IL-17 inhibitors, there's a problem in terms of inflammatory bowel disease. And there's been some debate or question as to whether this is a direct promotion of inflammation in the bowel or simply that the IL-17s fail to provide coverage for the bowel inflammation aspect of the seronegative disease, but cover other areas. So someone with active bowel disease and joint disease may improve with the joints, but not with the bowel. But either way, if you have significant concerns about inflammatory bowel disease or active bowel disease, then we shouldn't be using this. And there are some patients who get mood disturbances. IL-23 is actually remarkably well tolerated and tends to be relatively low risk, but like any of these drugs, isn't without risk. CD20s, because we most commonly use chimeric CD20s, which is heart mouse protein, infusion reactions are more common, hypertension, and reactivation of viruses, especially hepatitis B. So you may need to consider antiviral treatments if someone has previously been infected with hepatitis B. Hypergammaglobulinemia, a bullous reaction, and although it's incredibly uncommon, we probably do need to let patients know about PML, which is progressive multifocal leukoencephalopathy, which is a very unpleasant neurological side effect, but really more associated with its use in cancer care. For the BAF, infusion reactions, allergic reactions, occasionally joint pain, mood disturbance is possible, and PML is possible. For the JAKs, we're looking at cytopenias, herpes simplex infection, skin infection, particularly with herpes. This has had a little bit of a discussion, perhaps a bit of a storm in a teacup about the ACS risks, but with tofacitinib, the post-surveillance monitoring, could it have a high VTE risk, a high ACS risk? Even so, I think we have to be honest with our patients to say that these are undergoing post-marketing surveillance, and we probably wouldn't choose a JAK first line in over 65s, patients with high risk of cancer, patients with high risk of blood clots, patients with high risk of cardiovascular disease. We could choose it despite them having those factors, but I think we should have explored other drugs first and be willing to justify it. Now, in time, this may turn out to not be a major concern, and that is what the latest data is suggesting. But I think you'd have some explaining to do if you went straight for a JAK in those situations. Interferons, infusion reactions, headaches, viral infections, especially herpes, rashes, and deranged LFTs are possible. And for abatacept, again, if you're giving it as an infusion, it may give reaction, upper respiratory tract infections, and GI upset. And there's, because of their function, maybe there's that concern about cancer risk as well. So, initiation. And now, if you're going to be starting any of these drugs, you're probably going to be going to SPC or some kind of a prescribing guide, whether that's MIMS or the BNF or your local hospital's policy. But just so that you've got some idea about how these are typically started and maintained. So for the TNFs, I'm going to use the drug name. I'm not going to use the trade name. And I think it's really important to know the drug name, partly because, especially with biologics, it gives us a clue. So, for example, iximab, the ixi refers to it being chimeric, whereas mumab is a human antibody, and the sept, for etanercept, is a fusion protein. So we kind of know a bit about the drug before we've even got started. And these drugs are increasingly going to be in biosimilar format. And while I wouldn't advocate for swapping and changing to the latest, cheapest biosimilar every time you can, we are going to see more push for biosimilars in all of these areas. And knowing the drug name is going to be increasingly important. It's certainly helpful for us to know both, because we'll need to know they're on Amgevita brand, so we know not to change the brand of the biosimilar that they're using, for example. But I think if we're not familiar with the drug names, then we certainly should be. So we can do some induction regimes for some of these. The infliximab is really the only one that we use intravenously. There is an intravenous induction you can use for golimumab. Why would we go intravenous? Well, maybe the patient has fears or concerns about self-injection. Maybe we have concerns about their compliance. And in some situations where you want to increase the dose, you may have some greater flexibility to up the dose for infliximab than for others. And then the maintenance, these are given at variable frequencies. So for someone perhaps where you have a more a higher concern of infection, something like etanercept may be useful because of the reduced duration of action. For someone who really hates injection, maybe golimumab might be useful. Certolizumab, being pegylated, was often chosen for pregnancy, but latest EULAR guidance is suggesting that actually we don't need to be too fussed about any of the TNFs for pregnancy and breastfeeding. IL-1 blockers, well, realistically, most of us are only going to be using anakinra, and that's partly because although canakinumab is incredibly useful, it is very expensive and often prohibitively so, and so it's reserved for a small number of patients, perhaps with most aggressive forms of fever syndromes. Rilonacept, I don't think is going to be in common use, but it's a fusion protein version of an IL-1 blocker. These are all subcutaneous medications. Anakinra is a daily one. You may be giving this as an ad hoc, or you may be giving this as a regular to perhaps reduce the risk of things like amyloidosis that can occur. So IL-5 blockers, realistically, most of us are only using mepolizumab, so benralizumab will start to be seen a bit more. These are all subcutaneous, and most of them do not have induction regimes that go straight to the regular infusion 4 to 8 weekly, typically. IL-6 blockers, tocilizumab and sarilumab are the ones that are most likely to be around. There is an induction regime you can use for tocilizumab. You can choose to give this intravenously, or you can choose to give this subcutaneously. And then in the long term, you can continue this intravenously or subcutaneously, altering between weekly or 2 weekly, depending on the patient's weight. 12/23 blockers. There's an induction regime. This is a subcutaneous medication. This is based upon patient's weight, and then a maintenance regime, which is only every 3 months. So quite a useful drug if you have a patient that absolutely can't stomach injections. Unfortunately, ustekinumab has not shown itself to be a particularly effective drug in most situations for joint pain. It's good for bowel and skin, though. The 23s, there is a loading regime for these, subcutaneous, and then a maintenance regime, either 8 or 12 weekly. For our IL-17 blockers, we have some induction regimes and maintenance regimes. There's broad similarity between these. Obviously, there is ability to reduce things like bimekizumab to 8 weekly. There's some interest in bimekizumab being IL-alpha ANF, and perhaps that dual action of IL-17 blockade may translate to an increased clinical efficacy, but we don't have the data at the time of recording this to say that's the case. For our CD20s, I've put obinutuzumab because this is a fully humanized CD20 being used, but not commonly really in rheumatological sphere because it's not licensed. But it is an option if you really want CD20 blockade, but you're struggling with infusion reactions. This is where this might come in. And this is intravenous. There are different regimes and how you might deliver this. Quite commonly, we're giving 2 doses, 2 weeks apart, and then we repeat that on a 6-monthly basis. But that isn't the only way it can be given. You know, we could be splitting the dose to 1 gram on a 3-monthly basis, and there are different regimes for vasculitis and lupus you might want to consider. For belimumab, intravenous or subcutaneous with a loading dose and then a maintenance regime, either intravenous or subcutaneously. So finally, we come on to our last initiation. For the JAK inhibitors, none of these require initiation. Filgotinib was being used quite a bit in the UK, quite similar in some ways to upadacitinib. Pifocitinib I haven't used, but is another one of the JAK inhibitors that's out there. Most of these are given once a day. Tofacitinib typically twice a day. I believe they do have a once-a-day option available as well. It's worth being aware of the different subunit selectivities of JAKs. I think there are, as you can see in the way in which these are given, whether that's intravenous or subcutaneous or the frequency, there are obviously differences amongst the different subtypes of same class biologics. But I would argue that the differences between the different JAKs is bigger. Because this subunit specificity is more significant, and there are differences in terms of removal from the body. So what's liver metabolized versus what is renally excreted. And that makes a significant difference in your patient population. So they're not all quite the same class. And it's worth being aware when you're selecting this medication, how you're going to select your JAK rather than just having I always go to filgotinib or I always use baricitinib, because there might be situations where that's not the best option for your patient. Interferon blockers, really we have only anifrolumab that we're using ourselves. The others are having ongoing trials, and this is given intravenously 4 weekly. For T-cell blockade, it's an intravenous or subcutaneous loading, intravenous based upon weight, and then you continue this 4 weekly or weekly for the subcutaneous administration. What about monitoring of the targeted biologics? And this is where it gets a little bit vague. The guidance is perhaps a little bit less clear. I think for most of the DMARDs, you would probably wish to, but certainly the ones that I call the full-fat DMARDs, you would wish for a 3-monthly interval. Here, I think there are drugs that we probably should keep to 3-monthly, like the IL-6 JAKs and IL-1s, probably best on a 3-monthly. Some of these you could probably push out to a bit longer. So I think you could probably push TNF reasonably comfortably to 6-monthly monitoring. Same with belimumab, interferon, T-cell blockers. And some you may even push out further. So the 23 is especially, but 12, 23s, even 17s might be better on a longer interval, and others may be before the next infusion. So there might be patients who've responded fantastically to rituximab, and they don't require another infusion for 20 months, and you may not require monitoring until you're checking their immunoglobulins before the next infusion cycle. Special circumstances like pregnancy and breastfeeding, well, anti-TNF are safe. Rituximab, with some careful planning, could be safe-ish. Just trying to avoid it timing-wise in third trimester. All the others are very much a case-by-case. How bad is the disease? How much do I need to control the disease? Versus unknown risks. Probably will turn out that quite a few of these will be relatively safe, but we don't have the data, so we have to be advising that stopping is best at this time. JAKs, it would appear that these are best stopped because they're small molecules. They are likely to pass into the breast milk and across the placenta. Same is pretty much true for the biologics. Most are likely to be safe to continue, but the JAKs shouldn't really be continued when breastfeeding. Timing of surgery, again, this is based on ACR guidance that I put in the beginning, but it is you may vary this somewhat depending on whether you have a local approach. Generally speaking, the simplest way to think about this is when your next dose is due, you would be probably safe to have the surgery. It's not quite as simple as that. If you really want to be cleared and it's a really high risk, then 3 to 5 half-lives of the drug is best. But these are some recommendations that might be helpful. So if you're having infliximab, then you'd have it 1 week after so the planned infusion, the next planned infusion. So if you're planning to have it on a 4-weekly infusion, you would not have your 4-weekly infusion. You'd have the surgery from week 5 onwards, all the way up to, if you're having an 8-weekly infusion, then 9 weeks after your last infusion, when you're a week overdue, you could have your surgery. Adalimumab, we're doing it every 2 weeks. So by the 3rd week, when you're 1 week late, you can probably have your surgery. Etanercept from 2 weeks on, and so on and so forth, really, with that. For IL-1, 2 days after you finished it, and for canakinumab, at least 5 weeks, although the guidance here isn't so clear. Mepolizumab, guidance isn't very clear, but extrapolating the same kind of principles, we're looking at week 5, and benralizumab week 9 onwards. For tocilizumab, if you're on a weekly, at least 2 weeks, or if you're on a monthly, at least 5 weeks after the last dose. Bit of a long interval for ustekinumab because it's a 12-weekly dosing. Secukinumab from again 1 week after the next dose, and you can see this principle is largely continuing. Now, for the CD20s, you want to try and aim for the best point in the cycle of where they're likely to have recovered some B cell function. So by kind of month 4, hopefully you'll have had some new B cells graduate to B cell school. So between month 4 and 6, if you're on a 6-monthly regime, is the best time to do it. And obviously, if you're not on a 6-monthly regime and it's as and when, waiting for 6 months is ideal, because then you're well out of the range of having the rituximab working. BAF, week 5 on a monthly dosing. JAKs, from day 4 onwards, it does vary a little bit depending on each JAK. So I'm not going to go through those in quite the same detail, but quite quickly after stopping JAKs, you can have surgery. Anifrolumab from week 5, and abatacept, depending on subcut or IV, week 2 to week 5. So, vaccinations. So most of my patients, I'd recommend having influenza. That's in common with DMARDs and COVID. as we mentioned, local guidance. For some at-risk groups, having hepatitis A or B may be sensible, particularly on an occupation basis or where you are in the world. Tetanus is worth having this in date. HPV for at-risk groups and lupus patients. And as we mentioned, zoster, I tend to suggest a booster, especially if you're over 50. Avoiding yellow fever. And for other live vaccines, it's really worth being very cautious and doing this on a case-by-case basis. Now, one of the questions that comes up is the safety of vaccines in children, babies, in the first 6 months. And I think this is not an easy one to give a simple answer to. And it will depend upon how much maternal exposure happened during pregnancy and breastfeeding and a variety of factors. But you probably want to consider carefully the baby's vaccine schedule with regards to live vaccines in their first 6 months of life, if the mother is taking targeted biologics. Apart from just wanting to time surgery for the right time, you want to get the right time of vaccination, because your vaccine response is to produce antibodies. If you're preventing your main antibody cell, or you prevent it from maturing and being present, you're not going to get as good a vaccine response. So again, timing your vaccines month 4 to 6 is where you want to be at. So that's a lot of information, and I don't retain all of this in my head all the time. I have a sort of mental cheat sheet that I go through. So I'm just going to go through a couple of real basic cheat sheets, things that come to the forefront of my mind in clinical practice. So this first one is drug-based, and just what I think when I hear this drug. When I hear hydroxychloroquine, I think to talk to patients about eye safety, eye checks, and photosensitivity. When I think sulfasalazine, I think aspirin allergy and cytopenias, and to some extent, strongly positive ANA patients. For methotrexate, I want to know that their kidneys are stable. I think about liver function and alcohol use. I think about interstitial lung disease, but mainly pneumonitis rather than interstitial lung disease. For leflunomide, kidneys, liver function, lipids, and weight. And in long term, I do think about neuropathy, because I have had, unfortunately, a few patients get neuropathy, and it's quite a difficult one to manage. Azathioprine, I think TPMT beforehand, and random cytopenias. The TNF, I think TB and MS. Congestive cardiac failure when it's New York 3 or 4. And then I just think about which selection. So some of these TNFs are better than others in certain situations. So things like etanercept, not very helpful for iritis, or maybe less useful in axial SpA than perhaps adalimumab. IL-5, I think parasites. IL-6, diverticular disease, lipids and infection risk. 12, 23, and 23, I'm thinking fungus, and particularly candida, similar to IL-17. And I also think about inflammatory bowel disease. CD20, I think B-cell depletion. I think about hepatitis viruses, vaccine and surgical plans. For BAF, I tend to think about allergies and mood disturbance. And for JAKs, cancer risk, VTE, MACE, and skin infections, especially herpes. The other cheat sheet is just when I'm thinking about clinical situations and which drugs come to mind. So when I'm thinking of high infection risk, I like drugs that get out the body quickly, like etanercept. Rituximab, abatacept seem to have a softer profile for infection risk, and the 23 class of drugs seem to be pretty good for being well-tolerated infection risk. For interstitial lung disease, depending on the cause, things like rituximab and abatacept or IL-6 blockade, especially for scleroderma, can be helpful in managing that consequence. For iritis, I tend to think TNF monoclonals like adalimumab. For inflammatory bowel disease, obviously, this is just another thing. I think if they have that as part of their seronegative crossover, it reminds me to avoid IL-17s. And if they have diverticular disease, to avoid IL-6. And if they have hepatitis, caution with CD20s and CCF. So it's a different way of thinking about it. Finally, ACS, again, caution with JAKs. I know it's the same kind of information, but these are things that that I use. When there's a lot of skin burden, for psoriasis, for example, 23s and 17s do seem to suit better than your TNFs. I know that that might be too tricky from an insurance perspective, and for lupus interferons. So the key takeaways, because this is quite a long talk overall, but it has covered a very large topic. The pre-screening is relatively standardized. There are core parts of the workup, and then there are selected add-ons as per the drug. Patients need to be educated on the medications. They need enough information to make an informed consent, but without terrifying them with all the details of everything that could possibly go wrong. They need appropriate support and guidance to understand what to do if they encounter these things, and constantly also reminding my patients when you meet them, have you had your vaccines? Do you know what to do if you pick up an infection? Monitoring should be safe and effective at regular intervals. We talked about the counseling just a second ago about pregnancy, surgery, vaccinations. And obviously reassess the drug, make sure it's still necessary, make sure the rationale's still there, de-escalate if you can, choose a different lower treatment if you can. So what are my keep it simple, stupid guidances on all of this? Well, if I'm going to start any DMARD, I'm going to be looking at blood counts, kidney function, liver function. I probably would have done a height, weight, and blood pressure at some point as my assessment, but especially important for drugs like leflunomide. If I'm going to start anything that I consider full fat DMARD and beyond, I'll do a hepatitis B, C, and an HIV, and most of the situations I'll do a chest X-ray as well. The optional screens, I might add in lipids, immunoglobulins for B-cell depletion, double-stranded DNA and complement for belimumab, eye screens for hydroxychloroquine, and in more high-risk patients, varicella, CMV, EBV. I like to risk stratify my patients for their kidney, liver function, cardiac function, fibrosis, which we mentioned is not a contraindication to methotrexate. Bloods are done at baseline, week 2, week 4, week 6, then at week 12. Then follow them up with bloods and make a determination about when you're going to do bloods after changing the dose, like weeks 2 and 4 typically. For most of my patients, even though you can spread the blood tests out further for some of these biologics, I just think it's easy to do a 3-monthly blood because they aren't likely to get more than 3 months of a script out of the insurance, or simply from the basis of, if you, even on a state paid sector, if you give someone 6 months worth of a very high cost drug and they then have an issue, it's potentially a wasted drug if they have to put that in the bin. So 3 monthly, they get their script, and usually with their script comes a blood monitoring. It makes things simple. Maybe I'm over investigating some patients who are stable. I will be flexible. So in situations where someone may be on an IL-23 agent, they're very well, they don't have high disease activity, it's not convenient for them to come and have a blood test, they just want the next script, I'm not going to be a complete stickler and say, I'm not giving you the next script until I've seen your bloods. And obviously in other situations where someone has regular episodes of neutropenia, I might not feel comfortable prescribing on a blood test that's even 3 months old. So you're going to do this a bit case by case. Everyone should have annual risk stratification. So at least once a year, you should see patients who are on a DMARD or a biologic. And the risk stratification should look at cardiovascular disease, preferably with stratifying things like a Q risk, and lipids, HbA1c. You might include as part of that Q risk. Check the blood pressure, do the CRP for disease activity, and consider bone health assessment as appropriate according to the patient. I spoke a little bit about my practice, and I said that I don't do this counseling with my patients in every clinic because it's the same information and I'll forget something that I wished I'd said on a good day. So I tend to request that they go to my website in case anyone's interested. That is a QR code to my website. The drugs that I use have some information I've collated with a video I've created that I think is enough information for them to get going. There are links to external agencies where they can read even more about it, and they can gain greater understanding. This second QR code is to my YouTube video, which if you're watching this, obviously you're already here. But for the talk, it's a chance for you to come to the video to catch up on today's discussion on DMARDs. Finally, these are the references which I laid out at the beginning. So thank you very much for coming to check out this catch-up talk on DMARDs, and I hope that has provided a useful overview on some practical considerations when starting DMARDs and targeted biological therapies in rheumatic disease.